was on Prospect Street. So it was throwing me off.
On Prospect.
Hello, how are you?
Hello.
Morning, Dr. Gejerman, nice to meet you. Hello,
Hi.
how are you? Okay, I've been reading through your records.
Uh-huh.
Questions for you, and then we can talk a bit about the different options that you have. How old are you?
67.
Okay, and you are treated for high blood pressure, diabetes, and cholesterol. You've had H. pylori, correct?
I have it right now.
You're getting treated for it?
I'm seeing the doctor on Monday.
You've been treated,
I've been treated.
but it's not,
came
hasn't gone.
back, and can't get it to go away, so.
Are you having stomach pains from that?
Well, as long as I take the antacid,
Mm-hmm.
I'm fine. It masks it.
Got it.
But if I don't, yeah, then I get all kinds of problems.
All right, you quit smoking a while ago?
Yeah.
And what kind of cancer does your sister have?
Oh, duodenal or something. It's rare.
Mm-hmm. And how many times do you wake up at night to urinate?
Maybe once, maybe never.
Mm-hmm. Any hesitation in the urinary flow?
No.
All right, so I understand that your PSA was elevated and you saw the urologist, correct?
Yeah.
How high was your PSA?
When I first got it, it was 4.9.
When was that?
I don't know.
A few
About
months
6 months ago.
All right, and,
And then about 3 months ago, they tested it again, and it was 5.4.
Yeah, that was September. Okay, so you
Yeah.
saw Dr. Rosen. He did a biopsy on October 28th, and
Mhm.
that showed Gleason score
Of 9.
9 and 8. Let's see, right side, everything on the right.
Yeah.
And what kind of workup have you had since then?
What kind of what?
Workup, CAT scans, bone scans, that kind of stuff.
Yeah, I had a CAT scan and a bone scan, and everything came back normal.
Mm-hmm. Excellent.
In fact, we gave you the disc.
Yep, I have that.
Yeah.
Now.
Okay.
Got it. All right. So, what have they recommended so far? Have you started hormone therapy?
Well, Dr. Rosen does surgery, so
Yeah.
he recommended surgery.
Mm-hmm.
I didn't really want to go that route. I don't see too much advantage into doing that, really.
And he gave us your name
Mm-hmm.
to discuss radiation, and he hasn't started anything yet.
All right. Fair enough.
But he did say it would be radiation and hormone.
Correct. All right. So, look, this is what you have right now. The fact that it hasn't spread is excellent. This is treatable and curable. Whenever we see a man with prostate cancer, we need to know the Gleason score. Now, the Gleason score is based on Dr. Gleason, who was a pathologist who found that when you examine the biopsy under the microscope, the closer it approximates normal tissue, the less risky it is, the less chances that it'll spread. Okay? And it came up with a score from 2 to 10. 6 and lower is low risk, 7 intermediate risk, 8, 9, 10 high risk. Okay, so this is more high risk. Still curable, but it tells us what we need to do. So there's 3 options for all men diagnosed with prostate cancer. One option is to do nothing, which is called active surveillance. That's off the table.
Mm-hmm.
Nobody would recommend that for you. Option number 2 is surgery, to have a surgical removal of your prostate, which is a big operation, has lots of quality of life issues like loss of erections, loss of urine control. So if you cough, you bend down, you can wet yourself. I'm not opposed to surgery for the men that I believe it'll cure. When you have a Gleason score 9 cancer, very often once they operate, they come back and say, look, the cancer went through the lining of the gland, now you need to have radiation. So for those men, they have all the side effects of surgery, plus all the side effects of radiation, and there's no evidence that the combination of the two is any better. So I actually agree with you. I don't think surgery is a great idea here.
Mm-hmm.
If you had a Gleason score 6, yeah, then you would be a good candidate. But with Gleason score 9, I don't think it's a great idea. I think the best option for you is a combination of long-term, meaning like 2 years of hormone therapy and radiation therapy. Let's talk about the hormones. Hormone therapy means he gives you a shot that will lower your testosterone. The testosterone is the male hormone that feeds this cancer. Think of it like if your car runs out of gas, it's not going anywhere. Without testosterone, these cells cannot do anything bad. So the moment you get that injection from Dr. Rosen that will lower your testosterone, that stops the clock. The cancer will not spread. So I think it's important that we get that shot as soon as possible.
Okay.
So if you can get in there this week, try to get a shot, because that'll really just shut you down. Okay,
Mhm.
so the good thing about the testosterone blockade is that it'll stop the cancer from growing, it'll shrink your prostate, and it makes the cells more vulnerable to the effects of radiation.
Okay.
That takes about 8 weeks. So we don't do radiation until about 8 weeks after.
Oh, I see.
Oh, okay.
So the way it works is typically you start your hormone therapy. We'll wait about 6 to 7 weeks, and then we start planning the radiation. So you could actually start it 8 weeks after you've begun your testosterone blockade.
Mm-hmm.
Okay. Now, testosterone blockade is great to kill the cancer, but it has side effects. Without testosterone, all the good things about testosterone go away. So sex drive goes away. Energy level drops. You can lose muscle mass. You can get osteoporosis. You can be very tired. But if you exercise, you can avoid a lot of those side effects. It'll still impact erections, still impact sex drive, but fatigue is less of an issue. You won't lose muscle mass. You'll keep your bones nice and strong. So I want you to start exercising. 35 minutes of walking or riding a bike. Get some light weights, 10, 15 pounds. Do some weight training. Real important.
Can I take vitamins while this is going on?
Yes. Take a multivitamin like a Centrum Silver. Don't take anything else. Because some of the vitamins have a lot of antioxidants in them, which are normally good for you, but that's not good during the radiation. So the best thing is Centrum Silver. If you want to take some vitamin D and calcium, that's okay too. But just those three.
Okay. Now, when I'm getting how long do I get the shot for?
2 years. So every, Dr. Rosen has like different strengths. There's a 1 month shot, a 3 month shot, a 4 month shot. You'll work that out with him. But it doesn't say he gives you a 3 month shot. So every 3 months, you go back to the office, you get another shot, and that goes on for a total duration of 2 years.
Mm-hmm. Okay.
Now, that's first step. We do that. Then we're going to do radiation. There's two kinds of radiation. There's external radiation and internal radiation. The data shows that men that have Gleason score 9 cancer do better with internal radiation as well. So we're going to start off with 6.5 weeks of external radiation. You're going to come here 5 days a week. We give you a very sophisticated form called image-guided radiation, which I'll explain in a moment. About 2 weeks after you finish that, Dr. Rosen and I will take you to the operating room, and we're going to put catheters, little straws, into your prostate temporarily. And these straws are used as a vehicle through which we can introduce radioactive wires directly into the cancer. By doing that, you avoid hitting the bladder and the rectum because you're putting it right into the prostate, and it gives a very high dose of radiation, has an excellent chance of curing it. So a guy with Gleason score 9, a younger guy like you, that's what I would do.
And this catheter that goes in, is that painful?
No. You stay in the hospital for 2 days, so you come in Thursday morning, we do the procedure, which I'll explain. You'll stay till Friday night, and you gotta lay in a bed while these catheters are sticking out of you. You're gonna have a spinal epidural, which means we're giving you medication in your spine you're numb from the waist down. You will not even know that anything's going on down there.
Well, is it an injection?
No.
Oh, okay.
I mean, the spinal epidural, when they put it in, it's an injection, but that's one time. After that, you actually have like a catheter in your spine giving you medicine, and there's a button you can push if you're uncomfortable. So it's like a steady dose keeping you numb, and if you still feel uncomfortable, you'll give yourself some more. It's worked out really well. It's really not painful.
And
How does that compare to, let's say, CyberKnife?
The CyberKnife is exactly what I'm describing to you in terms of the external beam, which I haven't talked about yet. But instead of giving you a small dose each day over several weeks, you get 5 very large doses. Your rectum is here, right behind your prostate. That's your rectum. So if you give a large dose to your prostate, the rectum can really be injured. So there's no long-term data yet on CyberKnife. I know they're advertising like crazy, they're really pushing it, but if you ask them to show you 10-year results in terms of rectal toxicity, very little data. Particularly little data for men that have high-risk cancer. So this is a pretty aggressive cancer. There's very little data on CyberKnife for these aggressive cancers. I wouldn't recommend that for you. Not for 2 reasons. One, because I'm not sure it'll cure you, and I'm worried it's going to hurt your rectum. Okay? So let's talk more about the radiation. We use a sophisticated form of radiotherapy called image-guided radiation. I'm going to pinpoint the radiation and hit only your prostate gland and nothing else. So again, you start with the hormone therapy. So I want you to see Dr. Rosen this week. You get your shot. About 7 weeks from now, we're going to do a procedure. It's 2 things that I do in the operating room. It's under anesthesia, so you don't feel anything. So you come in, here to Hackensack. We'll give you anesthesia. It's like a colonoscopy. We give you some MAC anesthesia, we knock you out, so you don't feel a thing. You're on your back, legs up in the air. I'll put an ultrasound probe into your rectum. I'm going to put a needle on each side of your prostate and inject a tiny piece of gold. It's called a little marker. Then I'm going to inject what's called a hydrogel spacer. This is a compound that separates the prostate from the rectum. Again, your prostate's here, the rectum's literally behind it. What I do when you're under anesthesia, I put a needle in the space between the prostate and the rectum. I'll inject the hydrogel spacer, and that's going to push your rectum away. That really helps us protect your rectum. Now that hydrogel spacer is made out of hyaluronic acid. It lasts for about 3 months and then it goes away. Okay, so it's not going to be there, and you're not going to feel any of this. So when I put it in, you're under anesthesia. When you wake up, you can't feel the markers, you can't feel the hydrogel. Not when you're walking around, having a bowel movement, you're completely oblivious to it. Okay. A couple days after I put that in, we're going to do a CAT scan. So you come in, I'm going to make a cast for your body to help. It's like a cushion to help hold you on the table. And then once you go through the CT scanner, the computer will download 3D images of your body in the computer. Lasers will converge on your skin and will give you tattoo marks on your skin. I'll take the information from the computer and I will draw on the prostate that I want to hit, the bladder and the rectum that I want to avoid. The computer has an algorithm to calculate the dose and then you'll be in. When you come for treatment, you'll come every day, Monday through Friday. The way it works is we put you in your cast, you go into the machine. First thing that happens, the machine will take a CAT scan image of your prostate with a gold marker. Then the computer pulls up the original planning image and fuses the two. If your prostate moves, and it will move from day to day, the fusion software sees that, it will shift the table, put you in the proper location, and then multiple beams of radiation come from around your body, designed to hit only the prostate, nothing else. That goes on 5 days a week, 33 treatments over 6.5 weeks. I told you Monday through Friday, it's actually Sunday through Thursday. Okay, you get Fridays and Saturdays off. Okay, it's a 10-minute treatment, no nausea, no vomiting, no hair loss, you don't look different, you don't feel different, no skin irritation, your skin doesn't get irritated, none of that. You come in, you get your treatment, you can work, you can exercise, you can eat normally, no restrictions, just show up. That goes on for 6.5 weeks. When we finish that treatment, about 2 weeks later, we go to the operating room in Hackensack with Dr. Rosen. We'll give you a spinal epidural, so you're numb from the waist down. You're on your back with your legs up in the air. I'm going to take the testicles and take them up out of the way and put a special plastic template, like a little model, right up against your skin. And I'm going to put 25 needles through that area. Okay, all that's done under ultrasound guidance. Those needles are then replaced with a plastic catheter, like a little straw. And that's how we can get the radioactive wires in. So that procedure, where I put that plastic template up against your skin, put the needles and catheters in, I'll sew it on. When I'm done, Dr. Rosen will look inside your bladder. Again, you don't feel any of this because you have that epidural catheter. That whole procedure takes about 45 minutes. You'll then go to recovery, okay, to just recover from the anesthesia. Then we'll bring you down to the department. We're going to do a CAT scan. You do some planning, and then you'll get your first treatment. Now, you've got 25 catheters sticking out of you, okay, in the prostate. We'll connect those catheters to a machine that will deliver an iridium wire directly through each catheter into your prostate. It stays there for a few seconds, then comes out. Next catheter stays for a few seconds, and comes out. By doing that, I can put an enormous dose of radiation into your prostate without harming your bladder, without harming your rectum. And the data shows that men that get a combination of the external beam plus this we call HDR, a high dose rate implant, do much better. Your long-term cure rate's much better. So you stay in the hospital. So Thursday morning you come in, I'll do that 45-minute procedure with Dr. Rosen. By the time you recover, we do the CAT scan, we do the planning. You'll get your first treatment around 3 o'clock Thursday afternoon. I will disconnect you from the machine, and now you're not radioactive. We'll send you back up to the floor, and you stay overnight in a bed. You can't get out of bed. So we'll have a urinary catheter draining urine. We'll give you medication to constipate you, but you can eat, you can watch the ball game, you can read a book. You just stay nice and comfortable. Okay? Friday morning you come down, we'll connect you to the machine. The iridium wire gets delivered. Take about 10 minutes. We'll disconnect you from the machine. You go back up to the floor Friday, hang out till about 3 o'clock Friday afternoon. We'll bring you down for your final treatment, connect you to the machine, you get your treatment. At the end of that treatment, I take all the catheters out. and you go home Friday around 6 in the evening, we will send you home with a urinary catheter, but all that catheters up in your prostate, those are gone. So that combination of the 33 image-guided radiation treatment, followed up 2 weeks later by the internal radiation, delivers an enormous dose of radiation to your prostate, but it spares your bladder, it spares your rectum, and therefore you'll have very few side effects. During the radiation, you're going to be tired, initially from the hormones, and then also radiation adds some fatigue. It's not debilitating fatigue, but if you normally go to bed around 11, 11:30, now you want to go to bed 10, 10:30. You get a little extra rest to be fine.
Mm-hmm.
You're going to urinate more, okay, during the external beam radiation. So if you're only getting up once or twice, now it'll be 3 or 4 times.
Is that permanent or
no.
just temporary? Okay.
Temporary. And no incontinence. You'll always have control. You're just going to go a little bit more, particularly at night. Now that bothers you, I give you medication for that, like Flomax or Rapid Flow. I give you things. But even if I give you nothing, once we finish, that goes away. You're going to lose erections because the hormone therapy is just going to shut you down, hopefully temporary. And once we stop the 2 years of hormone therapy, you should get that back. That's a side effect. So when you come into the hospital and I do a procedure, there's always a risk of infection, bleeding, etc. But I've done hundreds of these, and I can count on one hand the number of patients that had infections or had any bleeding issues. So you should do really well.
Okay. How painful is the epidural?
Not at all. With epidural, what they do is first they do like a little lidocaine right around the skin, it's like a little pinch, and then the epidural gets put in. Some guys don't like it, but it's not pain, it's a little discomfort. It's minor. It's like getting your blood drawn. I don't think it's much worse than that.
Mm-hmm.
And the big advantage is then you have that epidural catheter and you're numb from the waist down. So it makes your hospital stay much more pleasant. We've tried to do this by giving medication just peripherally through the IV. It doesn't work as well. The spinal epidural really gets the pain.
So my legs will be numb, everything will be numb.
Yep.
Mm-hmm.
You'll be able to move them around, but you won't feel any pain.
Mm-hmm.
And you said he would go home with a catheter.
Mm-hmm.
For how long?
Monday morning, just for the weekend.
Just for the weekend.
How painful is it coming out?
Not at all. The pain of a catheter is the insertion. It takes 3 seconds to pull it out. It's not a big deal. So look, it's intense. It's an intense treatment. But fortunately, technology is such that we can do this without really, causing any side effects to you. There are minor side effects that I mentioned: the fatigue, the urinary frequency. That's pretty much it. That goes away. Long-term side effects: there's about a 10% chance of rectal bleeding. But with the image guidance and the hydrogel implant and the fact that I'm doing the brachytherapy, the high dose rate implant, your rectum's going to get a pretty low dose. I don't really anticipate any problems. If you get some rectal bleeding, it's going to be minor hemorrhoids, and if it happens, I'll give you medicine, it goes away.
Temporary?
Yep, everything's temporary.
Okay.
And the way we follow your progress is with the PSA. So once we finish treatment, every couple of months, Dr. Rosen takes your PSA, and your PSA should go to 1 or lower. As long as it stays there, that means that you're cured. So again, I'm being pretty aggressive with you. I think the high dose rate implant is a big procedure, but it has a much better chance of cure. That's what the data shows. And you're a young guy, you've got 20 years ahead of you. We got to get rid of this.
You think I'll get 20 years out of this treatment?
Yeah. That's what the data shows. Again, Gleason score 9 is a more high risk. So look, what I tell patients is that prostate cancer has gotten to the point now, we have an excellent chance of knocking this out with the first punch, which is why I want to really be aggressive with you. God forbid if I'm wrong, in 7-8 years it comes back. Well, there's hormone therapy, that could work for 3 to 4 years. There's immunotherapy, can work for 3 to 4 years. There's new drugs like enzalutamide, that could work for 3 to 4 years. There's chemotherapy, by then you'll be 100. So there's a lot that could be done that can just get your natural life expectancy. We've gotten to the point now where prostate cancer is almost like diabetes. You can't always cure diabetes. You can't cure it, but you can manage it for 25 years. Now, in your case, there is a chance that we can cure this, that we can knock it out with that first treatment. But even if we don't, we'll just keep you going for many, many years.
Okay. So you definitely recommend, rather than just do the external beam.
Correct.
Because
Yeah,
that's...
I sometimes just do external beam. Patients that are not healthy enough for the implant. Patients that can't come into the hospital, lay in bed for 36 hours. People that are anticoagulated because they have atrial fibrillation or heart issues. That's different. But whenever we can do the high dose rate implant, we do it because the data shows it's better.
Okay. And now the infection I got in my stomach, we don't do anything till that goes away or what?
No, treat it, but that has nothing to do with what I'm gonna do.
Oh,
No
Okay,
interaction whatsoever.
okay.
No, we should not wait. We can't wait on this. You need to start the hormones right away. I would do the hormones right away. I would book you to put in those Visicoil markers and the hydrogel 7 weeks later, and we should get started.
Okay, so it's gonna be the hormone treatment for,
2 years.
no, I mean, before I get the
7 weeks before.
Yeah, 7 weeks.
before. Okay.
Yeah.
And then after 7 weeks, I go into the hospital.
So 7 weeks after the hormone therapy, we'll do the Visicoils and the hydrogel. Then we'll do your external beam for about 6.5 weeks. And then after that, we're gonna do the high dose rate implant. A lot of stuff, I'm telling you, don't worry. We're gonna go over it. And I'm telling you, a lot of like detailed technology, all that stuff is behind the curtain. You come in, people smile at you, they'll take you into the machine, they'll take care of you. You don't worry about that stuff. We'll keep you on track. You don't have to remember any of this. We'll tell you each step of the way. Marlene will let you know when the time comes. We're gonna be on top of it.
Okay.
Any questions for me?
No, I think that's it. I'm just concerned about the fatigue and everything.
Yeah, that is a problem, but you can work past it. And again, it's not debilitating. It's not like you can't work.
Uh-huh.
You'll have to be able to work. Fatigue is more, at the end of the day, that is what anybody. Can I stand up, please?
Yeah.
Here, deep breath in and out. Deep. Deep. Normal breathing. Okay, I want you to drop your pants and underwear and elbows to the table. Turn around, that's it. What kind of work do you do?
I'm basically retired, but I make signs.
What did you do?
I was a representative for New Jersey Lottery, sales rep.
Any chemical exposure in the past?
Years ago, maybe in the
Separate your legs
80s.
a little bit. What kind of chemical?
I'm not sure, a lot of different stuff.
You can pull up. Who's your family doc?
Dr. Itali,
I never know how to pronounce his name.
yeah, something's close in
What's the
there.
name?
El Khalili.
Al-Khalili or something.
Where?
He's a field one.
He's in, yeah.
All right, so I'll send a letter today to Dr. Rosen and then email my team to call you. So the next step is for you to see Dr. Rosen. So I want you to call his office, let him know that you saw me, and I want you to start the hormones. He'll know. If not, he'll call me. We speak all the time. Then Marlene is going to set you up. My schedulers will set you up for the Visicoil markers and the hydrogel spacer about 7 weeks after you get the hormone shot. So Marlene's going to be in touch with you to clarify when you start your hormones. And then after that, we'll get started. Agnieszka Golubek?
No, that was the person in Saddlebrook that you saw, but that's not.
Yeah, I saw a different doctor in Saddlebrook.
But
Okay. Any other questions for me?
No, not right now.
yeah, I
Can't think of
I
nothing.
can't think of anything
All
either
right,
right
so
now.
call Dr. Rosen, set up the hormone suppression, and Marlene and my team will be in touch with you. If there's for any reason you don't hear from us, just let me know.
Any way you can put me to sleep and wake me up when it's all over.
Well, I use a lot of anesthesia. I do. I mean, look, the Visicoil markers, the hydrogel, there are some doctors that do it without a general anesthesia. They just use like a local. I don't believe in that. I like to keep you pain-free. So you're not going to feel any of that. The rest of what I'm talking about, it's not going to hurt. None of this is going to be painful. And even the operating room, I'm going to give you spinal epidural. I'm going to keep you stoned and happy. You're going to be okay.
That's what he's worried about. I know that's what he's worried about.
Okay, we'll work together on that. All right, nice meeting you.
Okay, thank you.
All right, so see Dr. Rosen, and we'll go from there.